All right, our next speaker is Leif Thompson, who will be speaking on genital cutting, enhancement, or mutilation.
Hi, good afternoon, everyone. Oh, wow, I can really hear myself here. Well, I'm starting with this picture. This is Gilfoss waterfall in Iceland, and my wife and I will be traveling there in about 2 weeks, and we're really looking forward to it. We have a friend that lives in Reykjavik, and we're going to take a road around the island, and I'm hoping to meet up with some of the people that were involved with the legislation there a few years ago. But you might wonder, what does Iceland have to do with my talk? Well, it all started with a family discussion. Iceland in 2018 proposed a law to prohibit the genital cutting of all children. There was already a law that existed from 2005 that prevented the cutting of female children. The law proposed was very simple. It would have only changed the word girl to child and her sexual organs to their sexual organs. Unfortunately, the law didn't pass. Pressure from the United States, Israel, other lobbying groups. There was criticism that it infringed on Muslim and Jewish freedom of religion, and also accused of being anti-Semitic and anti-Muslim. So in our heated family discussion with quotations, my position was that circumcision and female genital mutilation are ethically and morally comparable. And my sister's position was circumcision and female genital mutilation are completely different, and there can be no comparison. Have any of you come across this kind of thought? It's like comparing apples and oranges. Well, you have to actually sit down and compare apples and oranges. There's kind of three main ways to think about it. Are they the same? Are they not the same? Or are they kind of similar, some similarities, some differences? If there's no comparison, what can we say about apples and oranges? Nothing. The purpose of this statement is really to just shut down the discussion. It's like comparing apples and oranges, meaning we aren't going to talk about it. What can you say about apples and oranges? Well, they're both fruit, that's obvious, and that's a comparison. What can you say about circumcision and female genital cutting? They are both genital cutting. So after this discussion, my way of getting even with my sister, add 3 years, a lot of obsessive thinking, which I'm really good at, some research, a lot of procrastination, which I'm also really good at, add a pandemic and a bit of therapy, and I decided I am going to open Pandora's box, and the result was my talk, Genital Cutting, Enhancement, or Mutilation. It wound up being a 4-part lecture series examining genital cutting in its many forms, and the class wound up being about 6 hours of lecture time. But today I'm going to talk mostly about my conception for the class and some observations that I gathered. Obviously, I can't condense that down. I tried, but it didn't work. And I just want to say about my qualifications, I'm a family medicine doctor. I'm not saying that's the great qualification, but I also put on there that I'm a survivor of involuntary genital cutting. And I think it's important. When I was starting to think about how do I relate to this in a class, I was thinking, I'm going to be this objective person that's going to give out the information. And I really realized that I have to show my deep connection with the subject matter, and that comes from acknowledging and owning my own bias and my own experience. So early in the class, just coming up with a title was a struggle for me because I wanted to be able to discuss those two things on an even keel. Most of us in this culture are familiar with the terms female genital mutilation in the red on the left or circumcision in the red on the right. if you make a little grid on that, you're going to have things that are bad or mutilation in one column, things that are good or enhancement in the other column, and I'm trying to reach for the neutral so that we can discuss things in neutral terms. The idea with discussing things on neutral terms is I want to avoid the tautology, the circular thinking that happens when we say female cutting is wrong because it's mutilation and male circumcision is okay because it's not mutilation. That's really not a discussion, it's just a tautology, a loop. Neutrality forces us to discuss the merits, not our acculturation. So here's the title, genital cutting, neutral, descriptive, valueless, enhancement or mutilation, positive and negative, and that's value-laden. Some questions that arose earlier when I was putting the class together: who decides what's a mutilation and what's an enhancement? Is it a medical authority? Is it religious authority? Is it a collective culture? Is it governments, or is it advocacy organizations? Or could it be the person who has had their body cut? Are they the ones that get to decide if something is mutilation or not mutilation? That's the definition, or it's close to the definition that I would like. I consider my own circumcision is mutilation for me, but I do not assume that a circumcision on anyone else, voluntary or involuntary, is a mutilation for someone else. So putting the class together, rules of engagement, knowing that genital cutting is a really sensitive topic, I adopted some rules of engagement to circumvent our natural tendency to avoid sensitive topics, and also plan for the discomfort that results from discussing those topics. So as I talked before, start from a neutral place. The next principle I had was be fearless. All aspects are on the table for discussion. Sex, anatomy, sexual function. The cuttings are all to be explicitly discussed. Photos, videos of the genital alterations, as well as sexual arousal and intercourse are shown in the class. Objectivity is not possible. Everyone is coming from a position. So what do you do when we're not striving for that objective, beautiful objective position that's really impossible to get? I just assume bias is there in all cases. There is no unbiased perspective. Bias cannot be avoided, but it can be identified. And I do that by relentlessly comparing similar and dissimilar practices to provide a mirror into what our own biases are. I like to consider all forms of genital cutting together so that we can make those comparisons. That includes fetish cuttings, piercings, cosmetic, intersex, transgender. Much can be learned from this. And let's see, I'm going to get down there a little bit. I like to use emotions as a tool for understanding. Everyone's having emotional reactions to the pictures, to the discussions. Use that first to identify our feelings, then analyze. And there's no right or wrong emotions. Emotions just happen. We need to make space for that and expect strong emotions in the class. And finally, we need to use our imagination. To gain perspective, I needed to get a higher vantage point, and immediately my random brain goes to, oh, spaceship. I needed to get a higher vantage point, so I imagined that we're trying to talk with visitors from outer space that want to know about this. So we're hosting visitors from planet Zog. Zogonians prize objectivity, and they're very, very inquisitive. They ask, what pleasure part cutting? Why? Who is deciding to cut the genitals? Is it self-inflicted or imposed by others? Is it done for health, beauty, or status, or to change behavior? Does the cutting help society function better? And the questions just go on and on and on and on. Inquiring Zogonians want to know. So what would an ideal ambassador to Zog be an expert in? This is just a short list of what I could come up with. I could come up with way more. But the point here is that there's no one person that can adequately know the whole picture. The topic is just way too big. We can try, but it's huge. I'm going to go over the class outline really quickly, and then I'm going to go just to do a few random points that I picked up from teaching the class. I start with the introduction. First, I start with the mammalian obsession with the genitals. It makes sense. We need to procreate, hence the obsession with the genitals. But humans have this weird thing where we not only are obsessed with genitals, but we're obsessed with cutting genitals, which is kind of an odd human trait. Then I go into normal anatomy, histology, embryology, sexual physiology. You have to know where you're starting from to know what you're altering. Cosmetic cutting, piercing, fetish cutting, that's kind of my little road into the cutting world. Then I talk about some unique forms of cutting, Maasai cutting, Australian subincision, cults and cult emasculations and all sorts of weird things. And then I get into the female genital cutting, the WHO classification system, prevalence, distribution, Western cosmetic practices, patriarchy versus other cultural rationales for female cutting. And then I go into male cutting, history, religion, medical rationalization, detail of the foreskin, more detail in the foreskin and function of the foreskin and its loss to male genital cutting. I go into detail about my own personal history, and I think that's important to have that perspective within the lecture. And then I talk about short-term risks, photos of amputations and such things, and then long-term harms, hair on the shaft, webbed scrotums, psychological and sexual harm, long-term consequences of circumcision. Then I talk about intersex transgender cutting and the concepts of gender conformity and dysphoria versus genital conformity and dysphoria. And I won't go into it in the talk, but if anyone wants to talk to me afterwards, I have some ideas on that. And then I talk about foreskin restoration, female genital cutting restorative surgeries, ethics law, genital autonomy movements, and then I'm going to switch gears to my observations from teaching this class. So one of the first photos that I showed in class was this. Is this mutilation? Well, a common sentiment is like, I just know mutilation when I see it. But I show these two pictures side by side. The left picture would be the WHO female genital mutilation type 2A, I believe. And the right would be a typical male circumcised penis, which would be previously the normal American penis, and now it's seen as a variation of a normal American penis. I quickly realized that we don't have a functional definition of what mutilation is. So one of the first points that I want to make with this is that genital autonomy is a long and ongoing conversation. Bias and cultural conditioning are really hard to overcome. And I'm going to go through a bunch of photos of different cutting practices and is it mutilation or is it not mutilation? My class's goal was to make the strange familiar and to make the familiar strange. So now I'm jumping right into like deep dive here. So would any of you think this is mutilation or not mutilation? How do you know? How do you know it's mutilation or not mutilation? Well, in fact, these are sub-incisions from fetish culture, not Australian Aboriginal sub-incision. So this is self-desired and most often self-performed. And the desire is that exposing the urethra enhances sexual sensation for these men. For me, that would be mutilation. I would never choose this, but it's a chosen thing. Obviously, piercings, chosen. Here's some fetish infibulation practices. It's meant to enhance people's sexual activity or sexual pleasure or appearance. Then we have what's taking off in this country right now with labioplasty and hoodectomy, and they're advertised as not being causing reduction in sexual sensation, and actually hoodectomies are done specifically to enhance the exposure of the clitoris and hopefully improve sexual sensation. As far as labioplasty, I wonder, is this actually a form of genital dysphoria from our cultural pressures that are going on right now? I don't know. And I'm going to loop right back to the photo that we showed at the beginning. This is almost analogous to the cuttings that I was talking about with the labioplasty. It's seen by the WHO as an assault on women's sexuality and female genital mutilations. Roughly the same cut. You might say that the cultural cutting has a higher morbidity because it's not done under sterile surgical technique, but so is cultural circumcisions in other countries where it's not medicalized, and there is morbidity with that, and the WHO does not list that as mutilation. So what is the term mutilation based on? The intent of the cutter, physical result of the cut, a negative outcome, or the psychological experience of the one that's cut? Mutilation is highly dependent on who's doing the judging, and the term mutilation is elusive. It lacks objectivity. So the point on all of this is that the perceptions on genital cutting inhabit a really deep space in our down lower than the frontal cortex. It's mostly like down in the limbic system, and rational discourse on this is really difficult. Comparing circumcision and female genital mutilation causes cognitive dissonance. Are the practitioners, parents choosing circumcision mutilators? Are the religions, cultures, and the medicine that practices circumcision wrong? Are circumcised men mutilated? The mutilation label is much easier to accept when the practice is done by someone else, somewhere else, preferably very far away. Comparing circumcision and female genital mutilation, it's a threat to our very identity as good people. So we as civilized people, we're not mutilators. So this cognitive dissonance gives you an idea how much resistance there is to this comparison. The topic of genital cutting needs time and compassion, even for the cutters, and it requires courage from the participants in the discussion. Cultural evolution is painful. Acknowledge the pain. There are no enemies. We're all in this together. So this is a photo that I showed fairly early in the class, and it's comparing a girl and a boy both being genitally cut. Obviously, they're in pain. And how do we react to those two things? Well, the point I want to bring up here is that the feminist movement is both an important ally, but also an impediment to the larger genital autonomy movement. And I'm going to go into that in a little bit of detail. But I just want to go through this example because there's one student in my class where this was really hard for her to assimilate because in her worldview, that was from patriarchy and the subjugation of women, and that was, I'm not quite sure. So the term, what I want to say is the girl is seen as mutilation, violation of human rights, a tragedy. Boy, circumcision is normal. It's a cultural and religious and a parent's right. It's permissible and sometimes even something to celebrate. But do boys feel any less pain than girls? Do they feel the same pain, but should we care? So I'm going to just keep going because I have a feeling I'm going to run out of time here. But I'm going to go into the patriarchy. This slide will take just a little bit of time to go through. There's a problem with confounding patriarchy with men. Patriarchy is not the same thing as men, but in popular culture, this is confused all the time. Patriarchy is a system of power which subjugates women, but also subjugates men. Patriarchy is supported and opposed by both men and women, and patriarchy controls male bodies in similar but also dissimilar ways to women. Ironically, both feminism and patriarchy maintain that females are a class in need of protection and males are a class not in need of protection. From the feminist viewpoint, females are a persecuted class and males are a favored class. Therefore, females need added protection. Whereas patriarchy, females are weak and lack agency. Males are powerful and in control. So the problem gets when we're starting to think of that picture of the boy that's being cut. Boys and infants are in the system equated with men, yet they hold no power themselves. Boys, unlike girls and women, are specifically excluded from a class of persons deserving of protection. Boys lack moral status. That is the state of being worthy of moral consideration. So I'm going to go on to the next point. Circumcised men experience genital dysphoria and deserve a formal diagnosis to legitimize their suffering. Why would a man go through, the several years of stretching that's needed to create a pseudo foreskin from stretching what's left of the penile shaft skin? I come up with this idea that, that genital dysphoria really needs a diagnosis code in the ICD-10 or the ICD-11. We need to have a box to put these men in because until we do, they're just going to be the nutcases out on the side. And when we get a diagnosis, then it's like the field of dreams. You build it and they will come. It's just like that. So my definition would be a persistent and intense distress over the involuntary loss of the foreskin, together with a desire to regain the appearance, function, and sensation of an intact penis. So this would be like gender dysphoria. This is genital dysphoria for the man. Diagnosis is political. If you remember back to, I think it was 1973, the American Psychiatric Association took away homosexuality as a pathology, and that was with a lot of lobbying from gay people. Fifth point is genital autonomy movements should engage with the International Society for Sexual Medicine, and I'm getting pretty close to the end. They advocate for a full sexual life as a human right. They have a strong adherence to science and ethics, and the ISSM has just formed an advisory relationship with the WHO, so they might be a channel in to influence from a different direction. Unfortunately, the ISSM doesn't have a full understanding of our perspective on involuntary cutting, and they need to do research into that area. This is their mission statement, vision statement. Every human being has the right to a healthy and satisfying sexual life. To this, I would add, therefore, all humans, infants, children, and adults, female, male, and intersex, have a fundamental right to genital autonomy and to be free from involuntary or coerced genital cutting, except for urgent medical necessity. And the last point I want to bring up is humans' obsession with genital alteration is far larger than just circumcision and female genital mutilation, which was the whole subject that got me into this. We have the medical, cosmetic, fetish, cultural, religious, intersex, transsexual, and all of that stuff. And a lot can be learned by comparing even really odd things together. We need to explore societal pressures for genital conformity, just as our society is exploring gender conformity. There's a need for an overall theoretical basis for all genital alterations brought together under one ethical legal paradigm. There's a need for a textbook on genital alteration. The work is yet to be done. I'm proposing this as a title, but I think that's an endeavor worth doing. It's time to say farewell to our Zagonian visitors, and they hail us and say, "Live long, prosper humans, rejoice pleasure parts. When you pleasure part cutting know why, contact we." And with that, I'll open it up to questions. If I have any time, I probably went over a little bit.
We'll give you 5 minutes. We'll give you the full 30.
Oh, good.
We'll just cut into the break.
Yeah.
Thank you. That was wonderful, wonderful. I have a question about the ISSM. Are you referring to the World Association for Sexual Health and Dr. Elna Rudolph? Because they have a similar project going forward, and I've personally been working with her to build inroads into that. So is that just another name?
Well, this is the only name I know. I don't know the other one, but I'd love to talk afterwards because
Maybe
I
we
just
should.
became a member like half a year ago, and I'm just starting to learn about this organization. But I think that this is a lever that can be pushed on.
I agree 100%, and I would love to talk with you afterwards.
Yeah, yeah. What was the other organization you talked about?
The World Association for Sexual Health, and they are about sexual health and well-being. And Dr. Elna Rudolph is South African, and in a recent YouTube video, she made it very clear that genital cutting is something that should be freely chosen by people who have the mental capacity to do so, and that by no means should any child be genitally cut without an extreme medical emergency.
Yeah, I'd love to find out. I'm sure those organizations have connections,
Overlap.
but yeah.
Unfortunately, we don't have time for any more questions. We're very tight. I'm sorry about that. Thank you.
I was going to give him we could cut into the break. We can a couple of minutes.
Yeah. Okay.
Because we started late.
To them? Okay.
We've got about 4 more minutes.
Hi, so my dad graduated from medical school in the early 1960s, and he was introduced to the idea that circumcision wasn't such a good idea by his first year medical school teacher, one of his professors. So I was curious, so I think it's very important, the work that you're doing. I was curious where you gave this class, and also, what the possibilities are of bringing this class to medical school students, because my father got involved in it, and thus I got involved in it. So I think by educating medical school students, we can really make a lot of progress.
Yeah, I totally agree with that. This is a trial for me because I've been clinical medicine. I've never done classes. I've rarely done presentations. I'm quite nervous getting up in front of people. So I taught a course for OLLI, that's Osher Lifelong Learning, and it's for people that are over the age of 50. The classes are free or nominal fee. There's no grading or testing, and it's just an exploration. And I thought, well, the older group might be a little easier to get in and have my ideas accepted and stuff like that. But there were probably about 4 or 5 women in the class. It was mostly women. There was only one man. And the women had all had their children circumcised. And, that was a hard part of this because I'm bringing in the concept of genital autonomy, genital rights, and it's really difficult for them. And medical students haven't yet gotten into doing the procedure, but for the doctors that have been doing them for years, I'm introducing the idea that they're mutilators. And so, you have to find the language, the way to also show compassion for them at the same time that you're informing them that this is a problem. It's a tightrope walk. My goal is to this fall in November, I want to do a morbidity and mortality in the organization that I work. And I'm going to bring up a case of a male being circumcised as an infant, and it's going to turn out that male was me. So, I'm the product of that morbidity. And so that's my next step. After that, I'd like to speak at the residency in Anchorage, and then also speak at conferences and continuing medical education type things. I think that the problem is, your 3-minute, 5-minute bullet isn't enough time to get people to really understand the issue. And a lot of us are just, passing by. It's just, it takes a 6-hour lecture. I don't feel like I really got to where I wanted to be.
Thanks, Dr. Thompson. That was great stuff. You were mentioning ICD-11. Actually, I ran across an invitation for public comments for changes to ICD-11. So anybody in the room, you might think about that too.
Yeah.
Maybe I should post on Doc's website how to do that.
Oh,
But,
I would love that, because I think
for-
if now's the time, then we need to start thinking creatively about what the next set of diagnoses
Yeah.
would be. But the pathology's out there. We know that men are, I've experienced it, the distress. I've gone through counseling. I've been in preparation for this class. I went through a number of different counselors to get myself centered on this. And so there's a pathology that's the result of circumcision, and we need to make that a diagnosable pathology. Yeah, sorry, I go on too long with all the questions, but thanks for having me present. I really appreciate it. Oh, I have one last thing that I have to say, and thanks. What I want to do is thank all the women here, because it's not your fight, but you've made it your fight, and I just really appreciate it.